Welcome to our complete guide on Rivaroxaban, a powerful oral anticoagulant that has transformed the way we prevent and treat blood clots. Section 1. History of Rivaroxaban. In 2008, Rivaroxaban was first approved in Europe for preventing venous thromboembolism after hip or knee replacement surgery. In 2011, the United States Food and Drug Administration approved it for the prevention of deep vein thrombosis and pulmonary embolism. In 2012, it gained approval for stroke prevention in patients with non-valvular atrial fibrillation. Since then, its indications have expanded to include treatment and long-term prevention of both DVT and PE. Section 2. Introduction. Rivaroxaban is an oral anticoagulant. It directly inhibits factor Xa, a key component in the blood clotting cascade. It is commonly used for both the prevention and treatment of blood clots. Section 3. Structure. The molecular formula of Rivaroxaban is C19H18Cl N305S. Its molecular weight is approximately 435.88 grams per mole. The chemical structure can be visualized as a complex arrangement of aromatic rings, functional groups, and a sulfur-containing moiety. Section 4. Mechanism of action. Rivaroxaban selectively inhibits factor Xa. This action blocks the conversion of prothrombin to thrombin, which is essential for fibrin clot formation. Unlike some older anticoagulants, it does not require antithrombin 3 as a cofactor. Section 5. Medical uses. Rivaroxaban is used for multiple clinical purposes: prevention of stroke in patients with atrial fibrillation, treatment and prevention of deep vein thrombosis and pulmonary embolism, prevention of venous thromboembolism following orthopedic surgeries such as hip or knee replacement, in reduction of cardiovascular events in patients with coronary artery disease and peripheral artery disease. Section 6. Pharmacokinetics. Absorption. Rivaroxaban is rapidly absorbed after oral intake, reaching peak plasma concentrations within 2 to 4 hours. For lower doses, such as 2.5 or 10 milligrams, food does not significantly affect absorption. However, for higher doses like 15 or 20 milligrams, taking the medication with food is essential for optimal absorption. It is primarily absorbed in the upper gastrointestinal tract and uses specific transporters. Gastric pH does not significantly affect its absorption. Section 7. Pharmacokinetics. Distribution. Rivaroxaban is highly bound to plasma proteins, with a binding rate of approximately 92 to 95%, mainly to albumin. Its volume of distribution is moderate, around 50 liters, indicating that it mostly remains in the bloodstream and extracellular fluid with limited tissue penetration. Section 8. Pharmacokinetics, metabolism, and excretion. Rivaroxaban is metabolized by liver enzymes, primarily CYP3A4, CYP3A5, and CYP2J2. About 33% of the drug is excreted unchanged by the kidneys. The remainder is eliminated through the feces following hepatic metabolism. Section 9. Pharmacodynamics. Rivaroxaban exerts its effect by directly inhibiting factor Xa, a critical enzyme in the coagulation pathway. By preventing thrombin generation, it blocks the formation of fibrin clots. This results in a predictable anticoagulant effect, making routine blood monitoring unnecessary. Section 10. Therapeutic uses. Key therapeutic applications of Rivaroxaban include stroke prevention in non-valvular atrial fibrillation, treatment and prevention of deep vein thrombosis and pulmonary embolism, prevention of venous thromboembolism after orthopedic surgery, reduction of cardiovascular risks in patients with coronary and peripheral artery disease. Section 11. Dosage and administration. For atrial fibrillation, the standard dose is 20 milligrams once daily, taken with food. For deep vein thrombosis or pulmonary embolism, the initial dose is 15 milligrams twice daily for 21 days, followed by 20 milligrams once daily. After orthopedic surgery, the recommended dose is 10 milligrams once daily. Dosage should be adjusted in patients with renal impairment. Section 12. Adverse effects. Common side effects include antral disturbances, Tate liver enzymes. Section 13. Drug interactions. Drugs that inhibit CYP3A4 enzymes can increase rivaroxaban levels in the blood. The risk of bleeding is higher when used with other anticoagulants, non-steroidal anti-inflammatory drugs, or antiplatelet agents. Section 14. Toxicity. Overdose of rivaroxaban can lead to serious bleeding complications. The approved reversal agent is andexanet alpha, which binds and neutralizes the drug's effect. Because of high protein binding, dialysis is not effective in removing the drug from the bloodstream. Section 15. Clinical trials. Rivaroxaban has been shown to be effective in preventing stroke and atrial fibrillation and in treating deep vein thrombosis and pulmonary embolism. Clinical trials have demonstrated that it is non-inferior or even superior to warfarin in various indications. Its fixed dosing and lack of routine monitoring make it a preferred option in many cases. Section 16. Alternatives to rivaroxaban. Other oral anticoagulants include upsarin, abigatran, edoxaban. Each has its own benefits, risks, and monitoring requirements. Section 17. Brand and prescription information. Rivaroxaban is marketed under the brand name Xarelto. It is available in tablet form and taken orally. Section 18. Patient experiences. Many patients report a positive experience due to the convenience of fixed dosing and the absence of routine INR monitoring. However, patients must remain cautious as the risk of bleeding remains a serious concern. Section 19. References. For more detailed information, consult the following sources: FDD, a drug label at accessdata.fda.gov, DCIDs on rivaroxaban.day, impartial and affiliate and Xarelto prescribing information from the manufacturer. Closing statement. That concludes our comprehensive overview of rivaroxaban. Thank you for watching. Be sure to subscribe for more in-depth medical and pharmacology content.